Sam just texted me that the elevator was out. So we're going to do discussion first and then y'all, just so that, you know. So we'll work on that first. Okay. What else did I need to do? Oh, this is yeah, it's over there. So don't forget, y'all need to turn in your case study answers. Thank you very much. Thank you. All right, so we got a minute. We're gonna work on discussion first, and then we'll do the case study. But Charles told me that I have to tell y'all all of these Easter jokes. So are you ready for this? I couldn't remember them all. I had to take a picture of them. All right. How does Easter end? With an R. Yeah. What kind of, did I tell you this one? What kind of books do bunnies read? Ones with hoppy endings. What did the mommy egg say to the baby egg? You're extra special. Let's see. How does the Easter bunny stay fit? He exercises. This is my favorite one. Why did the Easter egg hide? Because he was a little chicken. Isn't that one cute? That one's cute. That one's cute. What happened to the egg when he laughed? To the Easter egg when he laughed? He cracked up. He cracked up. All right. Lots of Easter jokes for the week. All right. So what we're gonna do is we have the case study today, but we'll do that second. And I just wanted to pull this up and remind everybody, when is chapter 8 homework due? The Monday that we come back, and then the Tuesday, the next time I see you, will be an exam for 17 and 18 and the case studies. Okay, good. Which means, oh my God, I have a lot of grading to do to get it back to y'all in time before the final exam. Would have been nice to do before, but that's okay, right? It's okay. All right. You also need the chapter 18 section questions. So if you didn't get them yet, they're up on the front. What I'm going to suggest we do is work from the bottom up. I think like the first and second sections are pretty straightforward, but the later ones are a little more complex. So let's start with 8.14. We'll do those two, and then we'll go to 8.3. We'll do these two, and if we have time, because I don't think we're going to have time to do them all. But I think we're missing a few people today. So maybe having the case study second will give everybody a chance to get here if they're just running late, you know. So if y'all wanna just make one big circle and work together, that's cool with me. But I don't want to go too far. So let's like do two at a time, and y'all let me know when y'all getting close, and we'll talk about those two. And what I'm going to do is I'm going to pause the recording, I think. All right. So number 7, of the 3 mechanisms associated with methotrexate resistance, which mechanisms might be overcome by developing a structure-based drug design? Well, what are the 3 mechanisms? Did y'all remember that?
Single drug, which is binding of genetic mutation.
So the gene gains a point mutation in gene. So what does that do? Decreases drug binding affinity. Okay, that's one. What are the other 2? So gene duplication amplification. AMP. Amplification. So what does this do? Like the first one decreases drug binding affinity. What does the second one do?
It's too much for the drug.
So it's like a competition, right?
Okay.
So you have more protein product from the gene, more protein product from gene. So you saturate the drug, and then you have free, it's not necessarily an enzyme, but free protein left. Right? So it can go and do its cell division or whatever, get around the cancer cell has, right? Okay, what's the third one? It leads to multi-drug resistance. So, but what is the cellular response? Right, first one was a point mutation. Second one was we're amplifying the number of genes in the chromosome. Overexpression of membrane transporter that does what? That exports toxic drug. And so what does this do? It removes the drug from the cellular environment. Sure, you could say decreases concentration, yeah. Okay, so what we're trying to do, right, is to use a structure-based drug design. So which one of these is going to be affected by a structure-based drug design change? Only the point mutation. Only the point mutation is going to be affected. That's exactly right. Now, if you have a higher affinity, you might have a slight effect on gene duplication, but it's just going to make more copies. It's just going to keep doing it. So a point mutation is not really going to affect this one. How about the membrane transporter? It's just going to pump it out. As soon as it comes in, it's just going to pump it out. Right? So do you just want to, if somebody starts to become resistant to whatever chemotherapeutic you're giving them, do you just want to make one adjustment to their regimen? You're probably going to want to say, okay, well, we're going to give you a different drug, right? That has a different affinity. We'll maybe try a different inhibitor of the membrane transport, right? Yeah, and then maybe you want to target some other cancer cellular pathway, right? Because we showed there were all kinds of different ones, right? You remember that? Yeah, they're just a different gene target. Like this is targeting only one gene, right? So maybe you want to target more than one. Okay, how about number 8, right? All right, so when we convert adenosine to deoxy ATP, right? What are the 4 enzymes that are required? What reactions do they catalyze? And then how does SCID occur with mutations in adenine deaminase? All right, so let's come down here. Okay, what are our 4? Okay, so phosphoribosal transferase. Okay, so what does that do? So what are you starting with? Adenosine plus what? PRPP, and we're going to make AMP.
I'm not understanding where you're pulling this.
Okay, so what we're trying to do is we are trying to make DATP, right?
Oh, no, yeah, but like, where's the figures?
So this is in the beginning. Remember when we were talking about creating the different bases, right? I don't remember which slide number. I mean, I can't tell you offhand. Yeah. So you can look at the is it on the salvage pathway? I think it's on the salvage pathway and it's on the de novo synthesis as well.
Oh, so that's part of section 30.
Well, it's kind of all integrated. It's kind of all integrated.
Okay.
Yeah. All right. What's our second one? Adenylate kinase. Because are we at DATP yet? No. Okay, so adenylate kinase, we're going to start with our product from number 1. We're going to start with AMP, and what are we going to do to it? We're going to add an inorganic phosphate, and we're going to make ADP, okay? Then number 3, what are we going to do? We need to convert from the RNA form to the DNA form, right? So what enzyme converts it from ADP to DADP? Ribonucleotide, NUCLE, ribonucleotide reductase, right? Because it's a reduction reaction where all we're doing is taking off the hydroxyl on ADP to make DADP, right? Okay, and now what? Now we have DADP and we want to go to DATP. So that's another kinase, right? So this is a nucleoside diphosphate kinase. So do y'all see the pathway there? You're just building. Okay, so the next part of the question said, if you have ADA skid, right? Where do you have a mutation? What do you have a mutation in? Adenosine deaminase. So what are you doing with adenosine deaminase? So you're starting to break down, right? You have to think, is this a synthesis enzyme or is this a degradation enzyme? This is a degradation enzyme. Okay. So if you have a mutation in a degradation enzyme, you are going to have a lot more adenosine, right? DENOSI, adenosine, right? If you have lots of adenosine, what else is going to eventually pile up? ATP, right? From the reaction we just talked about.
Oh, because it's going to continue going through adenosine conversion. It's not going to.
You're just going to continue to make more DATP. Okay, so remember when we talked about regulation of production of each of the individual nucleotides, right? And there were 2 sites on an enzyme. What was the enzyme? Ribo ribonucleotide, what? Reductase is regulated by what two sites? By two sites. The specificity site, the S site, and the A site, which is the activity site. That's exactly right. So DATP binds the A site, and binding of DATP in the A site reduces what? Well, decreases of everything, right? Because the S site, specificity site, are we going to make more GDP? What, you know, which of the individual ones are we going to make more of? But the A site is the activity for all, right? A site is the activity for every single one of them. So if we bind DATP to the A site, we're going to have decreased overall enzymatic activity. So if you stop making all of the nucleotides, right? What's going to be the problem? So you stop making all nucleotides. The rapidly dividing cells are most affected. Dividing cells most affected, like immune cells. Example, immune cells. And then you're immunocompromised and you have SCID, right? Yeah.
I was like, I don't know, I knew this was coming from at first when I was.
Yeah, I know you're just gonna. All right, so that's like our time. It's 9:38. So I am going to vacate the premises and let y'all take over, okay? All right, so let me disconnect here. I'm like, what am I disconnecting? Here. Stop share. Okay. And I'll share screen on this one. Okay, so y'all can come up and pull up your presentation. Oh, I'm gonna need that out. I'm moving. Take my spot.
Take a seat. Can you hand me the chair? Yeah. Just like a...
Woo.
That's almost coming out, isn't it? Yeah. There's your phone. Well, the problem is you might need to stand on this side then. Yeah, I'm just gonna log in and switch. That's fine.
There are a lot of heart attacks in these studies. But it's, I mean, it's actually pretty relevant for the area of the country we live in. Architecture, very, very common down here. Good, that way it'll be easier. Guys,
Yeah.
tell y'all, one day.
It's a tripping
It's not
hazard.
so bad. It's not so bad in this class, but in my other class that I teach in here, I think I've almost died like 3 times from that. Reactions.
I even said, there's a cord right here. Let me plug it back in because it was almost out.
Yeah.
And you just, that will look you up then.
Nearly took me
That's not what I need. Hold on. How do I present again? Oh, here. Woo! I hope you don't mind that I'm sitting down. Due to unforeseen circumstances, I'm a little bed bound or chair bound in this case. So, since we're the only ones left, I feel like I don't need an introduction, but I'm going to do one anyway. My name's Sam. And our case study was case study 4, amino acid biosynthesis, or if you'd like to call it, a vitamin a day keeps the cardiologist at bay. Now, I don't think that's necessarily completely true, but
it sure doesn't hurt.
Sure doesn't hurt, yeah. All right, so let's start with our problem child, as we call it. 39-year-old man was admitted to the emergency department complaining of chest pain. He had a personal history of hypertension and hypercholesterolemia, which is high cholesterol and high blood pressure. He had experienced chest pain similar to how he was doing now about 2 days prior to admission. But like any person who probably doesn't want to go to the doctor does, it lasts for 10 minutes and it goes away and you're like, I don't need to see a doctor. It's fine. I don't need to spend the money on that. Not in this healthcare system. But then, day of admission, he gets chest pain that occurs at 6:30 in the morning. He was drinking coffee, watching television. The old morning Joe. Get your soap operas on. I don't even know if soap operas play at 6:30 in the morning, but it's fine. So let's look. Let me drag this up so that way y'all can see. So the first question is, does knowing the time of day help make the diagnosis? So yes, for the short answer, but I'm not going to give you just the short answer. So pain can be prominent at different times of the day, depending on the type of disorder, illness, or ailment that you have. So some things like muscle cramps tend to happen after exertion or during midday if you're doing something, because you're more likely to be active. However, myocardial infarctions tend to happen early in the morning rather than after exertion. So knowing that he came in had this pain at 6:30 in the morning can kind of help you go, okay, so he wasn't doing anything. So we know it's not a muscle cramp. So maybe we could look into his heart, because that's probably an issue. The second question is, what is the significance of the character of the pain? And the most important thing was that it was on his left side. Now, we all know basic anatomy of the human heart, at least enough to know that it's on around the left middle side of your chest, the left side. So, of course, the blood flows out through the left, it comes in through the right, and it's a whole mess of blood vessels and arteries and veins and all that. But a common characteristic of heart attacks is that you end up with pain and sometimes numbness. I've heard of numbness, but mostly pain on the left side of your heart and left side of your body, usually in your arm. You're like, oh man, my arm hurts. Oh shit, I'm having a heart attack. Oops. So that's a common characteristic of heart attacks, and left side is the first to experience those issues. So that's very important that was very important for the doctors when they were like, something's not right.
So is that true for all patients?
No, it's actually not true for all patients. So diabetic patients who experience heart attacks are actually less likely to come into the doctor, usually because they experience nerve damage. I believe it's not neuropathy. I don't remember what it's called, but it was nerve damage that usually prevents them from feeling chest pains and feeling left side pain. And then you also, like I said, like medical issues, they tend to have exceptions. Not everybody feels the left side pain. Some people will not really feel the pain as much as others. And then of course you have high tolerance people who will have high tolerance for pain and they'll just be like, I'm sore.
But a lot of times, go ahead.
Oh, and men and women typically experience different symptoms. Like men, like our patient in this case, have a lot more prominent symptoms, like a lot more chest pain, while women will have more like headaches, and they will have the specifically will have like the left heart numbness, something that they'll more be able to like more easily pass off as like aches and pains.
Women can have jaw pain, women can have back pain, women can have crazy symptoms that, well, so the thing is, right, there's no one classic symptom for heart attacks in women. So all the major studies have been done on men where there's this classic symptoms, right? And so then you don't publicize those alternative symptoms that occur in women. And so women are less likely to adopt.
I'm just
More
saying,
likely to die.
if we did like at least 2 more studies on women, we would have a little bit of a better idea of what happens between the male and female body, like for pains and stuff and the differences, because it's intense. Whoopsies. All right, so upon arrival, our fine gentleman was given crushed aspirin, and they performed an electrocardiogram, or ECG, as I will be probably referring to it from as now on. And it revealed inferior and anterior ST elevation. And I kind of discussed it in question 3, but I'll also discuss it here. The ST segment of the ECG will reveal the length of ventricular polarization cycle for your heart, or the time that it takes for the ventricles to polarize their current. And that's shown, so when you do your little boop, 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 like that part, it's that little part at the bottom that goes between the peaks, or not the peaks, the measurements. The picture, no. I
have one.
Yes, absolutely.
Because, so this is one of those things you're really gonna have to be able to look at.
I can't also draw it if that makes it easier.
No, that would probably be a little difficult.
I can walk, I just choose not to.
So here's normal, right? PQR ST. So the ST segment is right in there. So if you look for ST elevation, right? So this is a particular kind of heart attack. It's called a STEMI. Y'all heard of that before?
ST elevation, elevated myocardial infarction.
Can I add on to it?
Absolutely.
So like typically in a hospital, whenever they come in and stuff, they do like a 12 lead because it's gonna give them like a bigger picture.
So tell them what a 12 lead is.
So it kind of gives you like a whole picture of your heart, and you kind of can like pinpoint where to block it just
So
specifically.
they put the sensors in different places because you're monitoring the electrical activity in different parts of the heart. The 12 lead, how many leads is where front and back you're placing the electrodes.
I don't know if you know, but like there's some specific areas where like you want to look at to kind of see like if there's like actually an ST elevation. Because if you have an ST elevation like somewhere on the left, it could be something that was just like, you know, like you move and it picked up like a false reading. But there's some leads that you kind of look at like, is it this lead, and all 3 of them like, oh, I have ST elevation, and that's whatever you kind of see like, okay, you got MRI.
Oh yeah. So reading ECGs is like an art form, and like you have to be able to look at it very quickly and know what's happening. Like I know the basics. Like don't get me wrong, I'm not an expert. I know the basics, but I have a friend. She'll call me. She's an EMT. She works in Oshner, Maine, as a not as a nurse, as an EMT, as a paramedic, but she works like sort of like as a nurse. And she'll call me. She's like, oh my god, we had this STEMI, and on this lead it was this. I'm just like, I'm excited for you, but I don't know what all that means. It's all right. So y'all can take back over. Let me see if I can stop sharing. There you go. Then you just have to share that screen again. Yeah. So that's like only one lead. That would be that picture would be one lead, and you're looking at me.
Yeah, that's the reason why they do the 12 lead, because like if they just do that one single lead, it could be like this.
So when they saw that there was inferior and anterior ST elevation, they treated him with a bunch of stuff, such as nitroglycerin, heparin, and eptifibatide, and supplemental oxygen through nasal cannulae. Now, nasal cannulae, it's such a big fancy word for the 2-prong thing that goes in your nose that you see in all the medical dramas when you go through like a hospital procedure. That's all that is. And the pain in the ST segment elevation resolved after about 40 minutes. So let's look at why the crushed aspirin. Aspirin, well, as you mostly know, aspirin is an antiplatelet drug, which is similar to an anticoagulant, and it prevents blood clots from forming. It slows down the platelet cells from forming that blood clot. Therefore, you will be less likely to have a platelet blood clot blockage. And crushing aspirin causes the mechanism to act faster when in the body. because when you swallow it whole, it takes time to dissolve and metabolize. But when you have it crushed, it's more likely to just go straight into metabolizing. Now, a fun thing I actually learned recently from one of my other doctor friends is that they're studying literature on why you shouldn't chew and swallow aspirin, but you should put it under the tongue, because there are more blood vessels under the tongue, and it'll soak up the aspirin
Crush
faster.
it and then put it under the tongue?
You crush it and then put it under the tongue, because that's where you have a lot of blood vessels located, so it's more likely to suck it up, especially because they say that digestion takes too long, especially if you've eaten before. Yeah.
About it, sometimes I had to take medicine.
Mm-hmm.
Because it helps get that
Helps it
medicine
metabolize
into
faster.
the bloodstream faster.
Yep.
So I think that actually is a great idea.
So they're looking into like proving that you should probably do that more often. So next question, what are heparin and eptifibatide, and why were they administered? So heparin and eptifibatide are anticoagulants, which are similar to antiplatelets. I'm going to give you the same spiel. They slow blood clots from forming and dissolve existing blood clots. So it prevents more blood clots, just like aspirin does, although the mechanism is slightly different because antiplatelets specifically target the platelets, whereas the anticoagulants, I believe, work with red blood cells.
Well, so the heparin is a charged sugar, repetitive disulfide sugar that neutralizes some of the coagulation factors.
Ah, okay.
Whereas the drug, however you pronounce the drug, right, is another antiplatelet.
Oh, eptifibatide is also an antiplatelet?
It binds to the receptors on the outside of the platelets and prevents them from interacting with each other and fibrinogen in order to make the clot, right? Because the clot is
okay.
not just platelets. It's a combination of platelets and red blood cells and the fibers that run through it. Kind of like glue it.
Okay. So they basically work together. So the
So
heparin.
you're basically targeting different parts of the same pathway.
Gotcha. And that makes it more efficient.
Correct.
So like it stops the blockage from getting worse and works to dissolve the existing clot, because if you're preventing more clots from forming, you're also preventing that from getting bigger, which makes it more likely to dissolve naturally as it goes through the body, especially if it's not stuck.
Speed up a little bit.
Sorry. Patient history. He was a married insurance adjuster. He described his job as stressful, denied smoking and drugs, only did alcohol socially. Family history. His older brother had myocardial infarction at 45. Younger brother had coronary angioplasty at 42. Father died due to congestive heart failure because of several myocardial infarctions. Paternal uncles and aunts all have a history of angina pectoris. Mother's alive, has hypertension. Family history of smoking and supposed quote unquote heart attacks. And for the patient history, he denied history of chest pain prior to the 2 days. Sedentary but engaged in mild exercise without limitation. Denied having orthopnea, paroxysmal nocturnal dyspnea or pedal edema, which pedal edema is foot swelling, I believe. I know it's swelling for sure. I believe pedal is foot. No history of claudication, as I put cramping in the legs induced by exercise, stroke, transient ischemic attacks or mini strokes, and no personal or family history of diabetes mellitus, no history of headaches or cold, discolored extremities, and the medication that he takes is really just atenolol, which is for high blood pressure, and he takes 50 milligrams daily. So the questions: what are the familial causes of premature atherosclerosis and coronary artery disease? So like I said before, he had the history of angina pectoris, hypertension, congestive heart failure. All of those kind of say, hey, you might want to look at your heart, dude.
There was another big one when he came in. What else? Anything else notice? Like of all the indicators of coronary artery disease, he came in with a ton of them. Like family history, absolutely. Okay. He had high serum lipids, high, what else? High cholesterol, right? So all of, yep, all of those things. So he had quite a few.
Yeah, we ended up having that on the next slide, all the lab results and physical exam stuff. So question 7, what are orthopnea and paroxysmal nocturnal dyspnea and what do they imply? Orthopnea is breathlessness when recumbent, lying back, and it's usually relieved when sitting up or standing. So that can be a sign of heart failure. And paroxysmal nocturnal dyspnea is recurring shortness of breath at night. Usually wakes the person up, they lose sleep, and it's a common sign of left ventricle failure.
So why when they lay down?
I'm assuming because it puts strain on the. My mind just went completely blank. I had it.
So why do you have extra pressure on the heart when you lay down?
Because now there's no gravity working with it in order to push the blood. So it has to work harder to push that blood through.
If you stand up, the heart has to work harder because you're fighting against gravity. When you lay down, you're level.
Ah, okay.
So
I was thinking because it goes down, it would have gravity help.
what's the problem? Well, when you're standing, blood tends to pool down here, right? Down in your legs. So when you lay down, the blood very quickly comes to the heart, right?
And
So
it
you have
sits on the
more
heart.
blood coming to the heart. And then if you have some kind of damage to the heart, right? Well, you get that shortness of breath, right? Because usually it's it indicates a left ventricle failure, right? Because you're talking about what's going to happen if you have a lung phenotype. Usually that means you have a left ventricle issue because your right ventricle's working. It's pumping blood to the lungs, right? And the blood's supposed to return and then go to the atrium and then to the ventricle and then get pumped out. So if it doesn't get pumped out to the body and it backs up in the lungs, now you're gonna get fluid on the lungs. You're gonna have breathing issues, right? So it actually tells you about the location of the heart issues.
So, and for question number 8, that kind of adds on the headaches. Was this why was he asked about headaches and discoloration of the extremities? Headaches are a sign of the brain not getting enough oxygen. Possibly that could be where the blood clotting could be. There could also be an issue with a brain tumor, stuff like that. But more likely the blood clotting, since he already came in with the issues of the blood clotting. And then discoloration could be a sign of either lack of blood flow or even tissue necrosis, which can happen if you don't get enough circulation.
Yeah, but did they say it was blue? Did they say bluish? No, they just said discolored.
Yeah, they just said
Because
discolored.
if it's bluish, you know that it's a decreased O2.
Right, that's why I was like, any discoloration at all could either be
Yeah,
blood
it
flow,
depends on
oxygen,
eyesight,
or,
say the color.
yeah, and he denied having any, so he didn't have it. So physical exam, he was well appearing, no acute distress. His blood pressure was relatively normal because blood pressure is supposed to be 120/80. He was 129/81. His pulse was 67 beats per minute. His head, eyes, ears, nose, and throat exam showed that he had mild arteriolar narrowing. So his arteries were slightly narrowed, but there was no arteriolar venous crossing changes and no other abnormalities, meaning he was basically fine except for that slight arteriolar narrowing. His lungs were clear, auscultation and percussion, and his cardiac exam showed a normally sized heart, or normally sized in position PMI, not heart. And he had normal first and second heart sounds, and his fourth heart sound had no murmurs or pericardial friction rub. Sorry, I can't speak. His abdomen, he had a soft, non-tender abdomen. He had 0 masses. There were active bowel sounds, and he had no peripheral edema, so swelling in the peripheries. His pulse and his legs were symmetrical and of normal volume, which means that there was no change in the blood flow that was going through. And then I'll go into his lab results, and then we can cover the questions like real quick. So lab results, he had normal serum electrolytes, but his BUN levels were slightly higher than normal at 30 milligrams per deciliter. His creatine was at 0.9 milligrams per deciliter, and his complete blood count was normal. But his creatine kinase level was high, relatively high, at 330 IU/I with a 13% myocardial specific fraction, and it peaked at 1,073 with a 23% NP fraction. His initial serum troponin was at 0.27 nanograms per milliliter, which, as you can see, is very high, because the upper limit of normal is 0.03 nanograms per microliter. His total cholesterol was a little bit high, 242 milligrams per deciliter. At the upper level of normal is 200 milligrams per deciliter. His triglycerides were also relatively high with 252 milligrams per deciliter, and his upper limit of normal is 190. His HDL was rather low at 46 milligrams per deciliter, and HDL is the high density lipoproteins, which is a sign of good cholesterol, quote unquote, and LDL of 166, which the upper limit of normal is 160 milligrams per deciliter. That can specify that he might have too high of a lipid content. His serum homocysteine levels were incredibly high at 52.4 micromoles per liter, which the upper level of normal is 15 micromoles per liter, which indicates that there is some issue with his methionine and cysteine metabolism. And his chest radiogram was relatively normal, and the ECG revealed nonspecific ST and T wave abnormalities, which is the elevation that we saw earlier. So examination of the fundus of the eye was also done, and that's useful because the fundus of the eye is very susceptible to changes. So if you have changes in the body, it'll change, like the blood vessels will be changed because of those changes in the body. Like it's very easily affected. It's susceptible to a lot of changes because of that. So they saw, if they saw thickening and enlargement of the blood vessels, that would be a sign that there's something going on, which is usually what they look at. That's a sign of heart failure and blood flow issues. Significance of a pericardial friction rub is a pericardial friction rub determines the severity of an infarction. So the fact that there was no friction rub means that there was no infarction, or at least one that's so not severe that it wouldn't have been picked up easily.
Usually you have that post MI, so that doesn't necessarily tell them a whole lot about the heart attack that he had immediately that day, but it might give them information on the one that likely had, what was it, like 2 days?
2 days ago, yeah. So physical signs of heart failure: swelling, high blood pressure. We know that he didn't have a lot of swelling and fluid retention, but he did have high blood pressure, or he did have slightly high blood pressure. It was mostly normal though. And heart rate, which seemed normal. Coughing and wheezing, shortness of breath. We knew he had shortness of breath in specific moments, like the orthopnea and the paroxysmal nocturnal dyspnea. And he had a decreased ability to do any exercise, which wasn't true. He said that he could do mild exercise with no limitations. Fatigue, pain in the left side of the chest and the left arm. So now we look at what is creatine kinase and what does the increase in the serum signify. Creatine kinase is a cardiac enzyme, and an increase in creatine kinase is usually a sign of cardiac tissue damage, because when the tissue is damaged, it releases that creatine kinase and it goes into the bloodstream.
No, it's creatine kinase only in heart tissue. It's all in muscle, but there are different isoforms, and you can test the individual isoforms, right? So in this case, they tested for both total creatine kinase and for heart specific, right? That was the percentages after. So look at the percent, the heart percent went up. So then you know you had heart tissue damage.
The elevation in the level of homocysteine, what is the importance? Like I said, the homocysteine levels are an intermediate in cysteine and methionine metabolism. So seeing an elevation in that level can reveal a deficiency in that metabolism, and it could signal liver damage, kidney damage, and other issues. And then HDL and LDL, high density versus low density lipoproteins, and low HDL plus high LDL is a sign of high lipid content, which means that he has too much of the bad cholesterol.
All right. So they performed an angiogram on the patient and a cardiac catheterization to just map out and see what was going on in his heart. So it revealed moderate stenosis in a LAD artery in severe stenosis in a diagonal branch off of that LAD. So they went in and put a stent where the severe stenosis was. So they monitored him for a few days afterwards, and they sent him home on multiple medications, them being aspirin, clopidogrel, metoprolol, atorvastatin, valsartan, and B vitamins, them being B6, vitamin B6, B12, and folic acid. So let's see, what is PCI? I'm gonna move over here so it's easier to read. So PCI stands for percutaneous coronary intervention, which is a procedure where they insert a catheter to, they use a catheter to insert a stent to wherever the blocked blood vessels, arteries, or veins are, to increase the blood flow. They usually go in through like the thigh and just map it all the way up, depending on like whether it's a vein or artery, all the way to the heart. And all right, next question. What is a stent? It's just a very small little either metal or plastic tube that they that's made of mesh and typically coated in anticoagulant drugs so that there's not a relapse of the blanking for a second of the stenosis of the clotting of the stenosis.
So how do they place a stent? Like if you have this, you want to put it in this one particular place, how do you place it?
So they put the stent in the catheter, and like I said, they go in through a, just gonna hold it here for a second. They go in through typically the thighs because it's where a lot of arteries and veins are. They go into the thigh and just track it up through the body up until wherever the blockage is, typically in the heart. And depending on where it is in the heart, they'll use either the mesh or a cloth stent. That's a little bit bigger.
But so they put it around the balloon, right? And so the balloon is compressed, right? And the stent is collapsed around the balloon. And then they very quickly inflate the balloon. The balloon will actually kind of smash the atherosclerotic plaque on the sides of the vessel to open the vessel up. And then when the balloon deflates, the stent was collapsed and now it is
Expanded.
fully deployed, right? Expanded.
Fully deployed.
And it stays up, right? And it stays there, and then they can pull the balloon out. So the balloon is very quick, right? Because you don't want to cut off blood flow for a long period of time. But that's how they place it, right? Because you got to think it's got to be like the diameter of the blood vessel. Well, how do you get it in there? If it's the diameter of the blood vessel, you have to have it collapse. It's like the mesh, and then balloon it open.
Right. So what does this? What does the stent do? We kind of just talked about that. It opens up the blocked or the narrow veins or arteries to reopen the blood flow. And what degree of stenosis of a coronary artery is flow limiting? So moderate stenosis, which is 50% blockage, like 50% dilation or greater, is considered flow limiting. And question 20, what is the rationale behind the treatment with vitamins? So the B vitamins, B12, B6, 12, and folate, they all are involved in the metabolism of homocysteine. So the more higher vitamin levels will help lower the homocysteine levels, which I'll talk about in a second. And which is because homocysteine is typically associated with heart disease and strokes. So that's just preventative measures in case this happens again. And this is just a picture of an example of stenosis. So you can't really see it in the left side of the picture, but right here is a example of a severe stenosis. I believe this is a cranial vein or artery. So just an example of seeing like how constricted it is.
Pictures weren't very good at this.
Yeah, it was hard to see. All right. How might vitamin B6 and B12 supplement the supplementation combat atherosclerotic cardiovascular disease? All right, so cysteine is a promoter for atherosclerosis by increasing adhesion between the endothelial cells and white blood cells, specifically neutrophils, because I'm trying to remember the exact term, but they're the immune cells that are able to like go through blood vessels into combat infections. So B6 and B12 are cofactors in the homocysteine metabolism and increase their intake. Increasing their intake will increase the conversion of homocysteine into other metabolites. Homocysteine is a substrate in the biosynthesis of cysteine. Methionine. Which of these pathways is referred to as transsulfuration pathway, and which one is referred to as remethylation pathway? So transsulfuration is cysteine, and then remethylation is methionine. Easy enough. Betaine. Yeah, betaine. A product of choline metabolism, has been used to reduce homocysteine levels in patients with hyperhomocystinemia. What is the biochemical basis for the effects? So betaine and homocysteine, they are both catalyzed by the betaine homocysteine methionine transferase enzyme, which converts both the homocysteine into another metabolite in the homocysteine metabolism system.
Right, because when you have homocysteine and you add a methyl group to it, what do you make?
You get methionine.
Right? And so you take away that homocysteine from circulation, so you have less inflammatory effects.
So the methionine challenge test may be administered to detect defects in the homocysteine metabolism. Describe this test. All right. So the methionine challenge test, or the more common name I was able to find, the methionine loading test, is done by orally taking a load of methionine orally. I think it was about 100 milligrams.
Yeah, per kilogram.
Yeah. It tests if there's any defects in the cystathionine beta synthase enzyme by comparing the homocysteine levels in blood to the sulfates in urine, because these transsulfation, wait, what was it? Transsulfuration pathway gets the homocysteine out of circulation, and it eventually converts it into urine. Folic acid supplements in pregnancy has been found to reduce the risk of neural tube defects in infants, and experiments on avian embryos have shown that exposure to elevated homocysteine levels results in an increased chance of neural tube defects. So folic acid and homocysteine are both substrates for the methionine synthase. So an increased intake of the folic acid would increase the conversion of homocysteine into methionine. And this patient had an elevated blood urea nitrogen of 30 milligrams per deciliter. Okay, I just wanted to make sure. With the upper limit upper normal limit being 20. So this indicates that there was significant, or not significant. There was kidney damage. There was kidney damage at the very least. And about 85% of patients with kidney damage also had hyperhomocysteinemia. So there is a correlation there.
So how do you get rid of, what organ gets rid of homocysteine?
The kidneys.
The kidneys.
So if
you're
there's
not removing it,
then
you likely have kidney damage, and you see kidney damage a lot of times in patients who have hyperhomocysteine.
and that those are our sources. And yep.
All right, let's do some questions. Shall I?
For something like this, and if you're setting up a patient, something have recently what could there be any like dietary recommendations to help mitigate, help improve
Well, that would be
the health, like any like supplements, like in this case, like vitamins?
Okay, so they already did that, but if you're a dietary change.
Yes.
dietary change. Probably trying to think of the dietary source of homocysteine. That would be like proteins and stuff.
Well, so not necessarily, you don't necessarily think about a dietary change for homocysteine, but think about all the other factors that are impacting atherosclerosis, right? So if he has a really high triglyceride level, what would you tell him to do?
Limit fat intake.
Limit fat intake, right? If he has really high cholesterol, what might you prescribe?
Statin.
A statin, right? So you could think about those other things. You don't have to think about a direct ingestion, right? But all the other risk factors that are involved.
So mostly it would be recommendation of statin if you need. There would also be decreasing fat intake, and then I would probably, just in case as a preventative measure, also try to limit the amount of sulfur containing compounds you eat. So anything dietary that contains a lot of sulfates or a lot of sulfur in it, I would probably watch out for that.
Even if he was in perfect health as far as like his triglycerides were super high, very active eater, will he be elevated different? It is, I guess, the possibility of him having this major cardiac event.
Well, he was already relatively healthy, other than high blood pressure. Healthy people have heart attacks, but
I guess like does his family history of heart attacks have a bigger impact than anything he would want to do basis?
there's a lot of debate on like whether genetics have a bigger impact on your life than like diet and exercise. So his family history definitely would have come back to bite him at some point, whether it would have been sooner or like when he was 80 or 90.
There will always be a way that you need to at least check as a precaution to say, if nothing else, then to rule it out as the issue. So like so for example, I have a family history of high cholesterol and diabetes. So when they see that, they're going to look at they're going to monitor it very closely. And if I'm having trouble with something in my bloodstream, like if my blood pressure is high, if my cholesterol is high, they're going to look at, hey, this is a family history thing. So even though, yes, you need to look at your dietary intake, we also understand that genetics plays a factor and some of it may be out of your control. So it's not necessarily to say that it has an impact, as in it could be the factor that's not causing it, but it could be something to look for if you're struggling and there needs to be an answer.
My question is similar to hers, but how he describes his job as real stressful. Do you think that like, even though with his family history, that just like brought it on earlier in life, or do you think like he needs a more sedentary lifestyle now that he's had a heart attack?
Can you repeat your question? I'm sorry.
So like, you know how you described his job as stressful and stress leads to heart issues, most of the chest pain, and then that can lead to heart attack. Do you think that a more sedentary lifestyle would have like not have brought this about earlier in life, even though he has family history? Do you think it kind of would have subsided if he didn't have a stressful lifestyle?
Well, he already did say he had a relatively sedentary lifestyle because he said that even though it was stressful, he didn't really do a lot. He had mild exercise that he was able to do, but he was mostly sedentary. So I think lowering that stress could have probably helped, but I feel like he already had a relatively sedentary lifestyle and there wasn't much he could do on that aspect to be more sedentary in that case. But I think like lowering the stress levels could definitely have played a factor.
And still having a relatively sedentary lifestyle while still at least trying to have some mild exercise would be good to make it easier on his heart.
So my question's kind of about hyperhomocysteine. So I know it's said that it's rare, but like it has a lot of like, other health consequences like heart attack and like why do you think like we don't normally get tested? I know it's rare, but like if you can catch it, that should be something that might help you. Or like if you're having issues, I guess.
That's kind of just like rule of just like elimination, because if you're not going to test for like super rare stuff off the bat. Of course, yeah, it's very common in people with chronic kidney failure, but we didn't really know he had chronic, or he was having issues with his kidneys until they tested his blood urea nitrogen levels. So definitely something that they should test for, but something they should test for later on.
Well, I feel like given the family history, right, I'd love to get an extra genetic study. You know, try and get samples from as many family members as possible, and maybe some affected, some not affected, and see genetically, you know, do the ones that have the symptoms earlier in life have them. I'd love to. Genetics, yes.
I was looking at the Methionine challenge test. Did y'all see anything about controversy surrounding it, or?
Yeah, a little bit. Not. I didn't look too deeply in that, I'll be honest. But I did see some stuff about it. Not really being helpful for pregnant women.
Because this is the thing: if you're already suspected to have hyperhomocysteemia, then taking that methionine, especially when you have other risk factors that could like harm a baby or harm yourself, it probably wouldn't be the best idea to give somebody something that they can't metabolize.
I think it might be made up.
It's not used anymore.
Yeah, I just thought that was very, it says,
Inherent solvent, like,
So yeah, we're done.
All right, let me check the chat. Does chat have any questions from in the? All right, no more questions?
So I do have one. So why when you have hyperhomocysteine, do you end up having atherosclerosis? Like,
It was the was it cystothione beta synthase that you mentioned? No, it was the increasing the adhesion between the epithelial cells and the blood vessels and the neutrophils. Because I think it's the sulfide bonds in the surface of the neutrophils. I should know this.
so like think about you start from the beginning, right? You have homocysteine, tons of homocysteine floating around the bloodstream. Why is that a problem?
It's gonna clog up your arteries.
It's gonna oxidize, and you're gonna start making superoxide radicals, right? So then those raw species are just going to, there are multiple pathways that's going to increase inflammation. Gonna change the way the epithelial cells are arranged in the blood vessels, which is going to promote atherosclerosis. I mean, there are lots of pathways that's going to affect. So that's a really big, like,
Can we end the meeting?